Hello friends, in this video we will talk about the angina. So whenever next time anyone comes to you with the chest pain, there should be something on the top of your mind, and that should be the angina. So angina happens because of the myocardial ischemia or a reduced blood supply to the muscles of the heart. Now it's actually an imbalance between the demand of the oxygen for the muscles of the heart and its supply. Blood is supplied to the muscle of the heart with the help of the three coronary arteries. These three coronary arteries are the right coronary artery, which supplies the inferior wall and the right side of the heart. So these are the main distributions. And the left main stem divides into two other branches, which are, one is the left circumflex artery, which supplies the lateral wall, and left anterior descending artery, it supplies most part of the anterior wall. So these are main three arteries which supply blood to the muscle of the heart. So whenever there is a problem in the supply of the blood which is carrying the oxygen much needed for the functioning of the muscles of the heart, then there will be a problem which we call the angina. There are now you should understand the difference between two age groups. For example, if there is a 21 years old boy or a girl, and he has or she has got no risk factor, which I'm going to talk a little later, and there is a 60 years old person who's male has got some risk factor, then there will be a difference in the anatomy of the coronary arteries, to the extent that the coronary arteries of the aged person who also has got risk factor will have certain thrombus or atheromas, or there will be atherosclerosis, the process which builds up the fat clot in the coronary arteries, and these very clot, these become an impediment for the flow of the blood across the coronary arteries. So that is why the person gets decreased supply of blood and decreased oxygen supply to the muscle of the heart. So what are those risk factors? Those risk factor is on the number one, it is the age. Whenever someone gets older, the risk of having angina becomes higher. Gender, if a person is male, he has got more chances of developing the angina as compared to the female. But in females, it happens, this protection is only when the pre-menopausal age. But once a lady or a girl goes beyond the menopausal age, then this protection goes away. And then the female and the male, they have almost equal chances of getting the angina. So after age and gender, it's the family history. Family history, if someone has got a cardiac patient in the family and they have developed the heart problem at an earlier age. For example, if in male they have developed the heart problem before the age of 55 years, and in females around like 50 or 45 years, then the chances of the person who has got this family will be higher to develop the angina. So these three risk factors, which we call the gender, age and family history, these are non-modifiable. You cannot change these factors. So these risk factors cannot be altered. But there are certain risk factors which can be modified. And what are those risk factors which become a reason of a person to develop the atheroma and angina? These risk factors are the smoking. You can ask the person to stop smoking. So smoking is a risk factor. Then obesity. If someone is obese and someone is non-obese, then there will be a difference between the development of the angina in both these parties. Then there is a sedentary lifestyle. If someone is very active and physically fit, the chances of developing angina are less as compared to the person who has got a very passive or sedentary lifestyle. Like a person who's working in an office, doesn't go on jogging or walk most of the time, then the chances of developing the angina are high. So other than that, if a person is hypertensive and hasn't got a good control of the high blood pressure, then it's also a risk factor. Diabetes mellitus. Being diabetic puts a person at a higher risk of developing angina and its complication. And hyperlipidemia, if someone has got a higher level of the cholesterol and is not managing properly, then the chances of developing angina are really high. So these are modifiable risk factor. If you take good care of these risk factor, the chances of developing angina are less, because you have got less chances of development of the atherosclerosis or a clot formation, fat clot formation in the coronary arteries. So now let's talk about the types of the angina. How many types we have got? Mainly there are two major types which we are so familiar with. One is the stable angina, one is unstable angina. Stable angina happens during exertion or some emotional stress, or if a person has got exposure to the cold or some sort of physical or any stress, then the person can develop angina, and this angina will be relieved by taking rest or some nitrates, which are the dilators of the coronary arteries. Unstable angina is another type, and this is a worsening of the person who has sometime in the past has got stable angina. Now it is worsening. The person will develop the angina or this condition even at rest, and will be having it for a longer period of time, say around 15 minutes. Stable angina stays 3 to 5 minutes and person gets relief quite easily. So unstable angina is worsening of the situation. Now there are two other types of the angina, like one is the decubitus angina. When someone lies down on the bed in a recumbent position during night, then there is an increase in the preload or the blood which is going from the legs towards the heart. That puts an extra pressure on the heart, and the person will develop the symptoms of angina, which I'm going to talk in a while. So that is known as the decubitus angina. There is a very specific type of the angina which we call the prinzmetal or vasospastic angina. This happens because of the spasm of the coronary arteries. There are certain changes in the ECG which we call the ST segment changes. Person develops the symptoms of the angina, but once the patient is given some nitrates or the nitroglycerine, which are the venodilators, and they dilate the coronary arteries, the person gets relief. These are known as the vasospastic or prinzmetal angina. So these are types of the angina. Let's talk about the clinical presentation of a person who's suffering from the angina. The most important symptom in a person of angina will be the chest pain. The person will be having a pain in the chest, or there can be pain in the retrosternal area. This is your sternum. It's obviously a bone. The person will feel the pain, heaviness, or a choking sensation or a burning sensation right behind the sternum, this part. Sometimes people do develop pain in their jaws. They have the pain in neck, in arm, shoulders, or tip of the fingers. Those people who are suffering from diabetes for a long time and haven't got a good control of the diabetes, or a female aged person or other elderly person, they may sometime have atypical symptoms of angina, like they start feeling quite exhausted and weak. They will develop shortness of breath. So, and either an elderly person will become mute suddenly. So these are atypical symptoms of angina. So once you have received as a doctor a person who's giving you the symptoms of angina, how can you objectively diagnose that the person is surely suffering from the angina? There are certain tests which you can carry out in these patients. One, the gold standard test is the electrocardiogram or ECG. ECG stands for electrocardiogram. Electro mean electrical activity, cardio mean heart, gram, you get a picture of it. So you get a piece of paper on which there is a print of the electrical activity, and there will be certain changes in the ECG which will tell you that the person is actually suffering from the heart problem or the angina. In the stable angina, in between these attacks, the persons do not have ECG changes. But during the attack, patient will have some ECG changes. While in case of the unstable angina, there will be the chances are, because the pain lasts or stays more than like around 15 to 30 minutes, these patients who are suffering from unstable angina do visit ERs. They do get their ECG, and there will be either T wave inversions or ST depression. These are changes in the ECG. And these show that the person has got some heart relation with the chest pain or the symptoms with which the person has come in ER. So ECG is one of very important initial test. But 25% of the patient have got a normal ECG in spite of having the heart problem or the cardiac angina. These patients need to be retained in the emergency departments, and if the person has got the risk factor, you need to carry out ECG at multiple times at different intervals and also get the cardiac enzyme. So because the talk is about the angina, so I'm going to limit my talk rather than going towards the myocardial infarction, which is another type of the heart attack where there is a damage to the muscle of the heart. But in angina, there will be no damage, though there was a decreased blood supply to the muscle of the heart. And the cardiac enzyme are the test which make the difference between the two. In the myocardial infarction, cardiac enzyme become detectable or they are positive, but in case of the angina, because there is no damage to the muscle of the heart, so these tests or the cardiac enzyme are negative or not detectable. So if ECG is normal, you need to be very subjective in your approach towards the patient depending upon the presence or absence of the risk factor. There is another test. If ECG is normal, you can get the graded stress ECG test. That will be to make the patient run or walk on the treadmill, and there will be continuous monitoring of the heart rate, blood pressure and ECG tracing. This is a very important test because it sort of brings those potential clots in the coronary arteries which are not evident or they do not appear to bring certain changes on the ECG. Now, there are certain groups of the leads on the ECG which represent certain walls which are being supplied by a very particular coronary arteries. So, using ECG, you can actually know which coronary artery may probably have the clot which is causing the problem. So, this is important test, which is the graded stress test, or also known as the exercise tolerance test, or ETT. If a person cannot do the walk, then you can also do myocardial perfusion scintigraphy, where the heart is put under stress, and this is a nuclear test which can actually detect which part of the myocardium are under perfused. X-ray will be normal. In these patients, chest X-ray in most of the time are normal, but only if a person has got already some cardiomyopathy or cardiomegaly, that will be evident on the chest X-ray. You can also get another very important test, which is the coronary calcium scoring test. This is how you can also know about the problem of the angina. Lastly, the test of the choice in these patients who are suffering from angina is the coronary angiography. Angio mean blood vessel and graphy mean picture, and coronary are the coronary arteries which are supplying blood to the angina, to the myocardium or the muscle of the heart. So using the coronary angiography, you can actually see radiographically that which coronary artery has got the problem, and you can diagnose its anatomy as well. What we do during the coronary angiography, we use the radial artery. We can also use the femoral artery from the groin. We pass a catheter through the radial artery, and it goes all the way up to the aorta, and very near to the valves are the entrance point of the coronary arteries. And we are watching all this on the illuminator or fluoroscope, or we are radiographically visualizing this whole traveling of the catheter. Then we can inject a radio contrast right there, and we can look at the anatomy and structure of the coronary arteries and presence or absence of the clot. So all those patients who are suffering from the kidney problem, we cannot inject them with the contrast. So this is a very important point. Before coronary angiography is performed, a person needs to have the renal function test or the creatinine test. So coronary arteries will explain the exact problem. Now, once diagnosed, what is the treatment or management of these patients who are suffering from the angina? Now the management starts from the first you need to ask the patient to quit smoking, because the first thing you are going to do is taking care of the risk factor. Ask the patient to stop smoking. Secondly, take very good care of the diabetes mellitus and hypertension of the patient. You will have to advise patient for a very proper control of both of these problems. Then you also take a good control of the cholesterol level. All those patients who are suffering, who are having a high risk of the angina and the coronary problem, which we call the coronary artery disease, you make them to have their LDL, which is the low density lipoprotein level, less than 100 milligram per deciliter, because this is a bad cholesterol. All those patients who have got a very high risk of coronary artery disease or angina or cardiac angina, you make their LDL level come less than 70 milligram per deciliter. Keep their triglyceride level less than 200 milligram per deciliter, and HDL, high density lipoprotein level, which is a good control, is kept above normal. LDL is kept below normal, which is a bad cholesterol, and HDL, which is a good cholesterol, is kept more than normal level. So after taking good control of these things, you are to see if a person has got many risk factor and has had a problem of the coronary artery disease in the past, needs a very aggressive drug treatment and non-drug treatment. What is the non-drug treatment? You advise the patient to take, like do exercise, take a good care of the diet, avoiding the fat and cholesterol containing foods, and taking more vegetable and foods. These are non-pharmacological or non-drug treatment modalities. So what are the drug treatment for those patients who are suffering from angina? You give them the antiplatelet drug, which is the, you can give them enteric coated loperin or Disprin, which is an antiplatelet drug. Then you can also give another antiplatelet, which we call the clopidogrel. So you have heard Noclot or Plavix name. These are the brand names of the clopidogrel. So both of these are the antiplatelets drug. Then you can, if a person is suffering from the chest pain or pain anywhere which is related with the heart issue, then you will give the nitrates. You can advise them to have sublingual nitroglycerin, or you can also put them on oral nitroglycerin. Now there is a direct relation between the heart rate and the worsening of the problem. If a person has got a heart rate which is higher than 90 or 100, then the oxygen demand will be high even if the supply is compromised. So you need to keep the heart rate around like 60 to 90 beats per minute. For this thing, we give patients certain beta blockers. These maintain the heart rate. What are the one of the most famous beta blockers, like metoprolol? You can also give carvedilol. So these are beta blockers which are given to maintain the heart rate. For the very same reason, some people are put on the calcium channel blocker like the verapamil and diltiazem. And lastly, those patients who have this problem, in order to avoid damage to the heart, there are certain drugs which we give to do the cardiac remodeling. These are known as ACE inhibitors, angiotensin converting enzyme inhibitors, and one of the most famous is the captopril. So these are the drug treatment for a person who is suffering from the angina. There is a definitive treatment which we call the coronary revascularization. As the name implies, this is a way to revascularize the coronary artery. You re-establish the flow of the blood through the coronary arteries, which is much needed to carry oxygen all the way to the muscles of the heart. So what are the ways, like when you have done the coronary angiography, now you actually know what is the anatomical problem in the person. There are two ways to do the coronary revascularization. If a person has got, like the left main stem is involved, the person hasn't got anatomy is suitable for intervention, and person has got no LV dysfunction, and there are not so many risk factors, then you can do the PCI, which is percutaneous coronary intervention, or you can, this is also known as the PTCA, percutaneous transluminal coronary angioplasty. Angio mean blood vessel, plasty mean repair. You can pass a catheter either through the radial artery or the femoral artery, and you can go all the way up to the aorta or coronary arteries, and you can dislodge or remove the clot from the coronary arteries. This is known as the angioplasty. The person's anatomy of the coronary arteries needs to be suitable for this process. Person shouldn't be all suffering from the left ventricular dysfunction, and person should not be having a lot of risk factor. Otherwise, if a person, so when you do the PCI or the PTCA, then you have another option of putting in the stent. The purpose of passing the stent will be to keep the opened coronary arteries patent. Otherwise, these coronary arteries can re-stenose, and that will be a problem. And those stents which are drug eluted, they keep on emitting certain drugs which don't let the clot to reform in this area. So this is known as PCI plus stenting or angioplasty plus stenting. Some people do undergo angioplasty without stent, but nowadays majority of the people undergo PCI with stent. But all those people who have got LV dysfunction, left ventricular dysfunction, who have got a higher number of the risk factor, who are hemodynamically not stable, or their anatomy is not suitable, coronary arteries anatomy is not suitable for angioplasty, these patients undergo the coronary artery bypass graft, also known as the cabbage. So in this process, either we take the saphenous vein or the internal memory artery, and we maintain or make a bypass across the clot, so we re-establish the blood flow towards the myocardium from the aorta. So this is a definitive way of treating these people. So these are the basic things about the angina, and I hope it will help you understand a little bit. Thank you so much for watching the video.